Thank you, Amitoda. I'm deeply humbled and I'm in awe of the panel that I'm speaking. And my topic might seem a bit audacious, but all of you are in Kolkata and you got to listen to our story as well. That was the idea of giving this talk as one of the topics in this session. So I'm going to talk about government participation in healthcare delivery, specifically for congenital heart disease in the state of West Bengal. And we will see in the next I'll try and limit to sort of 10 to 12 minutes. See if there is a small model. So let's just understand our local problems a bit. What exactly is the congenital heart disease burden here? So we all know we have heard some brilliant presentations. It accounts for almost 1/3 of all congenital birth defects. So considering a CHD of around 8 to 12 per thousand live births, our population is around 10 crores in this state. So we would produce around 15 lakhs children per year. Now, if we say a median rate of around 9 per thousand, 13,500 children are born with CHD in this state. So that is a significant disease burden, out of which we all know that around sort of median of 2 per thousand live births would be severe CHD in the terms that they would require some sort of intervention or surgery within the first year of life, within the first few days or months of birth. So around 2,500 children in this state are born every year with such severe congenital heart disease. Are we doing justice to these children? Let us see the metrics of pediatric care, just the crude metrics in mortality rate and fetal mortality rate. So I've intentionally kept it till 2016 and we'll go further in the next slide. You see, this is the trend in entire India. And from somewhere in sort of 2007 of 37, we came down to 2016, we came down to 25. And this is the 2019 census data. And if you see, West Bengal is currently at 20. So we are not sort of doing too badly in terms of this. There are only a few states above us. Obviously, we are inspired by Kerala. We are inspired by their model. There's nothing to take away from better performing state. What I'm saying is, West Bengal is still sort of in if you take the top 10 states in terms of infant mortality rate, we are not performing too badly. Even if you take sort of neonatal mortality rate, that is also not too bad. We are around at 22. Now, this is a seminal paper by Professor Anita Saxena, which sort of analyzed, and this sort of is the benchmark for all such talks. So we know that we have a significant disease burden. There is no denying of the fact. According to this particular paper, which was which was sort of written in 2018, we were also contributory to the data. And things have changed after that. At that point of time, as per this paper, around 9,274 children were born with critical heart disease, as in severe congenital heart disease. 11.8% were actually treated. In the southern part of India, this was as high as 72. So there is a disparity. There are other areas. I'm not concentrating on that. So we know that there is a regional variation in access to care. There is a regional variation in way these diseases are tackled. And what are the main barriers for this? Why is it so main? I think we had a talk about funding. So I think the bottleneck of all this is mainly money. Where does the money come from to support this? Second is access. Do we have centers who can actually tackle this? Do we have a mechanism of early diagnosis and screening? And do we have a safe mechanism of transporting? Because not everybody will be born in an urban area with an access. And we will see whether we are doing justice in this particular state. So this is on the basis of hospital data, which I painstakingly collected from many centers. And out-of-pocket expenditure for, I'm talking only about congenital heart disease, intervention, surgery, CATS procedures. Only 30% is out of pocket. 45% in this state are funded by the government. Charitable organizations provide around 20% of this support, and a newer phenomena is crowdfunding. Some insurance do cover this, and that would be accounting for 5%. Now, in the year 2013, Dr. Arun Singh just talked about the RBSK scheme, and through that only the corpus of the fund came from the central government, and they started a scheme here called 2013 called Shishu Shati, which basically meant that any child who's born in this particular state would be given care for congenital heart disease, for intervention, for surgery, for whatever. And they had an aim of around treating 3,000 children per year. That was the aim, which was not very bad. It was a sort of a very high sort of target. How would we screen all of them? So we would screen them at birth with congenital heart disease, with crude methods of auscultation and other thing, nothing very sophisticated, like every child to get a pulse oximeter reading or something like they do in, I'm aware of the Kerala model. one thing which they did very well was they had a school's health screening program whereby they trained even Ayush doctors to screen for murmurs, and they would detect a whole lot of heart disease in there. We would see a lot of, so in the year 2010 to 2012, we saw an influx of undiagnosed heart diseases in this state for a significant period of 4 to 5 years, if I'm not wrong. And at the moment, 4 state-run hospitals and 7 private hospitals are actually tagged under this scheme. Till 2009, the model that we worked was all the districts in this state would actually be would be grouped into separate groups, and they would be then, after a screening has been done, would be tagged to a particular private facility, and they would be sent there. 2019 onwards, there was an interface of government which was introduced, and now all these districts were then tagged to a particular government facility where an expert committee would screen this, and then they would decide as to, in the 4 state-run hospitals, where they would handle it themselves or they would send it to one of the tagged private hospital facility. The government will actually send such documents like inviting the expression of interest from private partners, whether you're interested to run this at the rate that they're saying, and hospitals will actually fill up a form and apply for it. Then there will be a sort of paperwork, due diligence, and then a physical inspection of such private facilities by a government appointment team. Many of you have been part of such teams, which involve a pediatric cardiologist, a cardiac surgeon, anesthesiologist. Finally, if both the parties agree, there will be a signing of an MOU, and then we would work. So this is the patient flow currently in the state of West Bengal under this scheme. So screened patients from districts would go to a particular government facility, which it is mapped to. There will be a confirmation of diagnosis, and then they will either get treatment there or they will be sent to a tagged private healthcare facility, ensuring that every child who at least has come under the gambit of such thing with a diagnosis of a CHD has been sent to some place. There are special provisions whereby in some cases, if you require a special stent graft devices, you can apply for it. The expert committee will approve. It goes to the finance committee there, and then it will get an approval. Our system is not as electronic as the Hridayam. We are far away from it. I'm aware of the efficiency of I've seen their website. I've seen how real time it is. But here also, all our communications are through emails. So at least we don't rely on paper trails, and that gap between when we would request for something and the approval would come has significantly decreased. So these are some of the things. So this is how they would sort of actually tag districts into various sort of medical colleges, followed by them into a private healthcare facility, which would be tagged to them. So that is the current model. And let us just see as to what is the quantum of patients that have been treated under this particular scheme. We would talk about the financial viability of such schemes in a little bit, because that is a complicated subject altogether. But just look at these numbers. So almost more than 25,000 patients, and this is the data from the Shastra Bhavan, the government's data. These are the number of children who were cared for under the gambit of this particular scheme. And this is another very specific data which we have painstakingly collected from 3 participating government hospitals and all the private centers. And we have classified it into the total number of devices, cath procedures, and surgery. And if you can see, it is close to around 22,500 procedures. And well, there are some breaks in here. You can see there is a mark I have put for COVID-19, which slowed down things, and then things started picking up. And there are also sort of issues with funds with the state government, for which they would want to treat lesser number of children. But 1,000 children per year are still being treated under this scheme, even as late as 2022 till October. And there were years when more than sort of close to 3,000, which was the target. If you see the year 2018, 27, like more than 2,700 children were treated. In addition to this, the government hospitals also play a part. Around 1,600 children has been treated in 4 participating centers, 550 in one particular center. But there are some inherent challenges in this system. The main challenge is for private partners. If we go first, our communication delays. As I said, we're not completely electronic. Sometimes the urgency is clinical, and it might be a Friday night, and we would not hear from them till Monday, and that would delay things. We're not completely electronic like the Kerala model. There are significant payment delays, which makes it very tricky for private partners. And there is no separate provision for overstays of some critical patients. We know they might overstay, especially if you're dealing with neonates. There is no separate provision for a medical admission reimbursement. And sometimes there are delay for approval of special devices. Two of the main healthcare decision makers are on the dais. I just wanted to highlight it to them as well. And all this actually puts a question mark on the financial sustainability of these. If we go to the government sector, what are the challenges they face when they deal with these children? They have all these units are mixed units. They have a heavy adult load to deal with. There is a lack of trained manpower at all level, whether it is medical, whether it is nursing, whether it is anything else. There is a lack of, and there are also infrastructural limitations. And just to touch upon the financial part of it, this is the same RBSK rate which is followed throughout the country. So a tetralogy which be close to around 1.5 lakhs, a coarctation is compensated at 60,000. A switch is also 150,000. So more or less, these are all sort of fixed package things, which if the patient sort of touchwood has without an uncomplicated stay, will probably not bleed the hospital financially. Otherwise, there is a significant potential of that happening. However, if the case mix is okay, we would see any center, if you analyze the data, most of the cases, 50% would be VSDs and tetralogies, and then this thing. So you can still sort of at least keep it sort of roundabout viable if the case mix is okay. So as I said, there are special provisions. So these are the kind of letters that we would write, and expert committee will approve on a case by case basis. These are some patients who have been written for a Contegra graft. Then it goes to the finance committee, which has a meeting, and then they will finally approve it. Now, this process takes some time. Sometimes the patients become inoperable. Sometimes we lose them on the wait list. And what exactly happens to these patients, these 25,000 patients who have been operated? So the conglomerate data that we collected shows that an in-hospital mortality of around about sort of 5% if we combine the data from all together. Neonatal infections is still one of the main things when we go to the neonatal subgroup. The follow-up is good because 2 of these post-operative visits are actually under this scheme. So they would definitely come to us. Some of them would actually pay later also and come and follow up in the OPDs. So, ladies and gentlemen, I'll leave it to you to decide that whether there is a West Bengal model or not for this. So we've treated almost 25,000 patients, both surgeries and intervention, around sort of 5% in hospital mortality rates. The IMR, as we saw, is currently 20 here, which was significantly higher than this in previous years. So is the neonatal mortality rate. So with those remarks, I would just want to conclude that I think there is a West Bengal model. More than 25,000 children, these patients would not have access to care. We have not assessed it directly. This is just extrapolation of data that the IMR indicates that it has definitely contributed. Inherent challenges, especially the financial viability, does remain. It is not perfect yet, but the intention, I would say, is robust. And I think we have to iron out the edges to make this a viable program so that children who are the core of these would actually sort of benefit from this. This slide does not require any words. I think these are all patients who have been treated with various procedures under this scheme, including an ECMO resuscitation of an Alcapa with a severe left ventricular dysfunction. Every year, roundabout in the winter time, we get these post-operative device and surgery children to participate in a low-activity sport to give a message that all is not lost when you're diagnosed with CHD. They live as normal a life as a normal child. This particular child has a tricuspid atresia, has undergone 2 surgeries under this scheme, was initially a Glenn and now has been completed Fontan for the last 4 years. He has very good exercise capacity. After 1 year, we have stopped his anticoagulation because he really wanted to play football. He is the captain of his football team in the school. And if you see his exercise capacity, he is an exception in some ways. But I think if this scheme was not there, I think this particular patient, if we see, would not have access to this life at all. So I think with that, I would conclude that there are challenges we face, but in terms of numbers, I think because of the sheer population that we have, as I said, 15 lakh children are born every year in this state. So obviously, there is a significant subset of patients with congenital heart disease. There is an intention to treat. We'll see how robust it is in times to come. There are inherent challenges, but I think we have taken some baby step to address this particular aspect of congenital heart disease. Thank you for your patient hearing at this stage on a day. Thank you.